Hi everyone, welcome back to next level ophthalmology. Today we'll be dealing with the cranial nerves associated with the eye like the oculomotor, trochlear and the abducens nerve and supranuclear disorders. Let's start with the oculomotor nerve. The nucleus is located at the level of superior colliculus in the midbrain. It is a group of multiple subnuclei, of which the first one is levator subnucleus. It is a single subnucleus that is present in the superior aspect of the complex, and it supplies bilateral LPS. Okay. The next is superior rectus subnucleus, which supplies the contralateral superior rectus. Then we have the medial rectus, inferior rectus and the inferior oblique paired nuclei, which supply the ipsilateral muscles. So what are the features of an isolated third nerve palsy? Due to the action of levator palpebrae superioris being lost, we have severe ptosis. Due to the loss of action of the superior oblique, superior rectus, inferior rectus, medial rectus and the inferior oblique, the abductors, that is the lateral rectus and the superior oblique, are acting on the eye. As a result, the eye is down and out. This is what we usually describe an eye with oculomotor nerve palsy as down and out. So any effort to look downwards will cause intorsion because of the presence of a normal superior oblique. Then the pupil is fully dilated because there is an EPD, there is absent light and near reflex. So there is a big pupil and there is limitation of movement of supraduction, infraduction and adduction. So this is how the nucleus is present in the superior part of the midbrain, and then this is the oculomotor nucleus here. So nuclear lesions will always cause bilateral involvement of LPS, causing bilateral ptosis, then contralateral superior rectus palsy and loss of all the other muscles as we have discussed. So if there is a lesion involving only the medial rectus, you get something known as the Webino, that is wall-eyed bilateral internuclear ophthalmoplegia. So what are the features of this? The eye is in exotropia, it's wall-eyed. Secondly, there is no adduction, so bilateral adduction deficit. And thirdly, there is no convergence. So these are the clinical features of Webino. Next, the next part of the third nerve is the fascicle. Okay, the fascicle is very closely related to the cerebral peduncle and the red nucleus. So we know that if there is a lesion at the red nucleus, you get contralateral tremors. So this is known as Benedict syndrome. So it is characterized by ipsilateral third nerve palsy associated with contralateral tremor. Then if there is a ventral fascicle that is involved, usually the cerebral peduncles are involved. That's why you get contralateral hemiplegia associated with ipsilateral third nerve palsy, and this is known as Weber syndrome. In North-Nagel syndrome, you get involvement of cerebellar peduncle, and thus you get some cerebellar symptoms like ataxia. And then we have Claude syndrome, which is a combination of North-Nagel syndrome and Benedict syndrome. So these are the four syndromes I want you to remember with respect to third nerve palsy. Next, the nerve now is still a series of rootlets, and then on the medial aspect of the cerebral peduncle, they form the main trunk. Okay, here they form the basilar part, and this part is very important as the posterior communicating artery is present here, and this is somewhere near the circle of Willis. So the most common cause of a third nerve palsy is a posterior communicating artery aneurysm, which is usually associated with severe hypertension, and an aneurysm can rupture here and cause third nerve palsy. It can even compress the third nerve and cause third nerve palsy, and can be associated with the intracranial hemorrhage. If there is a head trauma, there is a intracranial hemorrhage and there is increased intracranial tension, then there can be uncal herniation which compresses the third nerve over the tentorial edge, leading to something known as a Hutchinson pupil. What is a Hutchinson pupil? there is ipsilateral initial meiosis followed by mydriasis and total third nerve palsy. It is an ominous sign. It shows there is uncal herniation and there is an urgent need to decompress the intracranial cavity. The next is the intracavernous part, when the third nerve enters the cavernous sinus and is associated with many other nerves. So you can have pituitary apoplexy, cavernous sinus thrombosis, Tolosa-Hunt syndrome, keratico-cavernous fistula as causes of affection of the intracavernous part of the third nerve. Remember, it is also associated with fourth, fifth and second nerve when the lesion is in the cavernous sinus. The next is the intraorbital part. The oculomotor nerve divides into a superior and an inferior part at the level of superior orbital fissure, and then the superior part supplies the superior rectus and the LPS, whereas the inferior part supplies the inferior rectus, medial rectus, inferior oblique and the pupil through the ciliary ganglion. Okay, let's take a question at this juncture. A 76-year-old hypertensive lady presents to the emergency with severe headache. Okay, we have two clues already: hypertensive, old lady, severe headache and decreased consciousness. So we are probably dealing with something known as a subarachnoid hemorrhage, probably. Okay, on examination the blood pressure is very high and the eyes show that the right eye is abducted and depressed. So the eye is down and out with complete ptosis and the pupil is dilated. So all these are pointing towards a right-sided isolated third nerve palsy. So which part of the oculomotor nerve do you think is the probable site of the lesion? We just discussed this. The basilar part is very commonly associated with the posterior intercommunicating artery aneurysm. So probably the aneurysm has been compressing the third nerve, and right now she has presented with decreased consciousness, probably due to the rupture of the aneurysm. So the answer here would be basilar part. So I would like to say a few things about the pupillomotor fibers. In the third nerve, the pupillomotor fibers are present more in the peripheral aspect of the nerve. Okay, so these nerve, the pupillomotor fibers are supplied by the pial plexus, which run along the surface of the nerve. So if there is a lesion that is compressing the third nerve, it presses the pupillomotor fibers quite early in the disease. So pupil involving third nerve palsy, also known as a surgical cause, is a must indication for neuroimaging. So this is known as a surgical cause because you are probably dealing with a compressive lesion. Whereas the main trunk is supplied by the vasa nervorum, which is the blood supply through the vasa nervorum, which enters the core of the nerve and supplies all the other fibers. So in a medical cause such as diabetes or hypertension, when there is some damage to the nerve because of the vessels or the vascular phenomenon causing a third nerve palsy, the pupil is usually spared. So pupil is a very important thing to decide whether the probable cause is surgical or medical, but this is not always true. Okay, this is true most of the time, but we know that nothing is absolute in medicine. Alright, so let's move on to the next question now. All are true regarding aberrant regeneration of the third nerve palsy. So whenever there is an aberrant regeneration, realize that it is a transection or a trauma that has caused the initial problem, after which the regeneration is happening in a haphazard fashion. Okay, so this is also known as oculomotor synkinesis because one movement is associated with other movement. Usually follows traumatic dysfunction of the oculomotor nerve, correct? So we are looking for something false here. Associated with axonotmesis, no. Okay, so there are 3 degrees of nerve damage: neuropraxia, axonotmesis and neurotmesis. So this aberrant regeneration is associated with neurotmesis, not axonotmesis. Then it may be associated with pseudo-Argyll-Robertson pupil, correct? So what is this pseudo-Argyll-Robertson pupil? We learnt in the last class, Argyll-Robertson pupil is absent light reflex and present near reflex. So in this aberrant regeneration, you can have a discrepancy between the two reflexes. The light reaction may not be as great as the near reflex, so you get a pseudo Argyll-Robertson pupil. There can also be globe retraction associated with vertical gaze, and there can be lid retraction associated with convergence. So this is a pseudo one graphase sign because there is no thyroid eye disease causing a lid retraction. It is the aberrant regeneration of the third nerve. So let's start with the fourth nerve now. It's purely a motor nerve with a slender long course and begins from the dorsal aspect of the midbrain and has internuclear decussation. So causes for an isolated nerve palsy are trauma, congenital and vascular. It's usually associated with other cranial nerve palsies. So let us understand what are the clinical features of a fourth nerve palsy. If there is, supposing there is a left-sided fourth nerve palsy, we can have left-sided hypertropia. So the eye is up, more up than the right eye, okay, due to unopposed action of the inferior oblique. Then there is increase in left hypertropia on right gaze. In the sense, on the opposite side, whenever there is opposite gaze, there is increase in hypertropia, and that is also due to unopposed left inferior oblique overaction. Then there is limitation of the left depression on adduction. So we also call fourth nerve as the copying muscle. As a result, there is worsening of hypertropia on opposite gaze and decreased depression. So the eye is not able to depress on adduction. So this are the three features of isolated fourth nerve palsy. So what is the abnormal head posture that we have? There is an opposite head tilt. So supposing we are dealing with the left-sided fourth nerve palsy, there is a right-sided head tilt, right-sided face turn and a chin depression. So right-sided head tilt is to compensate for the loss of intorsion. Right-sided face turn is to compensate for the absence of abduction, and chin depression is to compensate for the absence of depression of the eyeball. So let's take a question at this moment. True about right-sided isolated fourth nerve palsy. So let's just revise what can happen in right fourth nerve palsy. There is right hypertropia. Okay. So there is right hypertropia which worsens on left gaze and which is better on left tilt. So just remember these two things. Contralateral gaze worsens the hypertropia and contralateral tilt betters the hypertropia. Okay, so diplopia is present in primary gaze. Yes, it can be present, and the diplopia is usually vertical and it worsens in down gaze. Correct. So this is right. The head is tilted to the right side. No, the head is tilted to the left side. There is left hypertropia. No, there is hypertropia of the right side. Okay, because of the unopposed action of the right inferior oblique. Then hypertropia worsens in right gaze. No, worsens in the left gaze. The right answer here is A. So we can have a small mnemonic here to remember. Worsens on opposite gaze, voog, and better on opposite tilt or boot. So these are the 2 points which will help you to understand and remember fourth nerve palsy. Fourth nerve palsy always worsens on opposite gaze and is better on opposite tilt. So let's come to abducens nerve now. The abducens nerve is located at the junction of pons and medulla. So pontomedullary junction, and supplies the ipsilateral lateral rectus. Okay. So the palsy would cause a horizontal diplopia which worsens in the direction of the lesion. Suppose there is a right-sided abducens palsy. So while on looking to right, the diplopia worsens. So because of unopposed action of the medial rectus, you will have esotropia. Limitation of abduction, that is the function of lateral rectus, is lost. and the phase turn is on the opposite side of the lesion. Because the diplopia is worsening in the direction of the lesion, the phase turn will be on the opposite side. So let's have a look at its location in the brain. So here is the nucleus starting from the pontomedullary junction. So a lesion in the nuclear level can give rise to a ipsilateral limitation of abduction. Also remember, it's very closely related to something known as a parapontine reticular formation, okay, PPRF. So this is responsible for gaze because it is receiving impulses from the cortex, motor cortex, which is asking both the eyes to look in one particular direction. So gaze is when both the eyes are going in one particular direction to look at something. So when there is an affection of the nucleus here, it might involve the PPRF also. So that can cause a gaze palsy, which I'll explain in the coming slides. So if it is associated with the 7th nerve, which is very close to the 6th nerve, it hooks around the 6th nerve. So if there is associated 7th nerve, you can have a element palsy. So this is about the nuclear lesion. After that, the nerve comes out from the ventral aspect of the brainstem, and this is known as the fasciculus. Okay, it's very close to the pyramidal prominence. Also, it can cause foveal syndrome as the fasciculus passes through the PPRF. It is also very close to the other nerves. So the 5th nerve affection will cause facial anesthesia. Then 6th nerve associated with gaze palsy may be there, 7th nerve palsy, and then central Horner syndrome, and 8th nerve deafness can be there. So if it is associated with the pyramidal tract, you can have a contralateral hemiplegia, also known as the Millard-Gubler syndrome. So coming to the basilar portion, it is the nerve further travels along the petrous apex and then enters the Dorellos canal. So here the nerve is very susceptible to damage due to raised intracranial tension, and the structures of the brain can stretch the 6th nerve nucleus, causing a isolated 6th nerve palsy, what we call as the false localizing sign. Why do we call it false? The lesion is something else. There might be a tumor somewhere else in the posterior fossa or somewhere else, which is causing a raised intracranial tension. So this raised intracranial is causing a 6th nerve palsy, thus we call it as a false localizing sign. The lesion is not at the level of basilar part of the 6th nerve. The lesion is somewhere else, but it is looking like an isolated cranial nerve palsy. Okay, so other causes for affection of 6th nerve in this area are acoustic neuroma, nasopharyngeal tumors, and skull base fractures. Grady-Negro syndrome is 6th nerve palsy associated with mastoiditis or petrositis. Then the next is intracavernous and intraorbital parts. It's usually associated with affection of other cranial nerve palsies, which I have discussed previously. So let's take a question now. A 22-year-old man presents with severe headache and vomiting. Okay, so these are the features of raised ICT. He also has diplopia and is diagnosed as left-sided lateral rectus palsy. So left LR palsy means the left eye is rotated inwards. There is left esotropia, and this worsens on left-sided gaze. Okay, worsens. So fundus shows papilledema. So here we have all the clues suggesting a raised ICT associated with a isolated 6th nerve palsy, which we just discussed is known as a false localizing sign. So what is false about this patient? He has uncrossed diplopia. This is true. Usually esotropias are associated with uncrossed diplopia, whereas exodeviation is associated with crossed diplopia. Diplopia worsens in attempted left gaze. True. We just discussed this also. The palsy is reversible. Yes, once you bring down the raised ICT, the palsy can be reversed. The site of affection is the basilar portion of the left in all cases of isolated abducens palsy. So this cannot be true. We cannot say everything absolutely. We can have fascicular portions of 6th nerve also affected without causing any other nerve affection. So the answer here is D. Now let's talk about supranuclear control of the eye movements. So what do you mean by supranuclear? Above the 3rd, 4th and the 6th, there is a control from the cortex. Okay, so So this control is needed when you need conjugate or binocular eye movements or versions. So when both eyes have to move together, we need a supranuclear gaze palsy. So this, conjugate eye movements can be either saccades or pursuits. What do you mean by saccade? Saccade is a fast fixing movement. It's a very quick movement when something enters your visual field. Whatever movement of the eye is needed to fix on that particular object is known as a saccade. Whereas pursuit is when you are interested in that object and you want to pursue that object and the object is moving within your visual field. The movement of the eyes, which is a slow pursuing movement, is known as a pursuit. So what are the types of gaze palsies? In gaze palsies, remember, there will not be any diplopia because both eyes are behaving like one unit, and then there will be normal vestibulo-ocular reflexes. So the lesion is above the level of the nuclei. So these are known as supranuclear gaze palsies. So it can be either horizontal or vertical. We are more concentrating on horizontal gaze palsies, which are of three types: gaze palsy, INO or internuclear ophthalmoplegia, and 1.5 syndromes. So let's understand horizontal movements. How is it controlled? So if I want to look towards my right, impulses from my left eye frontal eye field, that is in the frontal lobe, travel to my right side PPRF or the paramedian pontine reticular formation. Why is it paramedian? It's very close to the midline, and then it enters the sixth nerve. From here we get impulses traveling directly to the right lateral rectus, and there is an interneuron which connects two nuclei. Interneuron is a neuron which connects two nuclei. It crosses over to the other side and connects the oculomotor nucleus. So this interneuron, which is highly myelinated, is known as the medial longitudinal fasciculus or MLF. So this connects the abducens of the right eye to the oculomotor nerve of the left eye. So suppose I want to look towards my right, the parapontine of the right is activated, causing contraction of the right lateral rectus and the contraction of the left medial rectus. So this is what happens normally. So if a patient's right horizontal gaze has to be initiated, where is the lesion? We just discussed this. It should be in the left frontal lobe. So what happens in internuclear ophthalmoplegia? So let us understand. The lesion is at the medial longitudinal fasciculus. Remember, this is a very myelinated tract, interneuron connecting ipsilateral sixth nerve with contralateral third nerve. It is very close to the midline. So why am I stressing this midline? Because it is very common you involve both sides. So when there is a small lesion involving just the left sided medial longitudinal fasciculus, just think about it. Let's see what happens in the left INO. So left sided INO means the eyes are straight, there is no diplopia. On attempted right gaze, there is inability to adduct, and there is a abducting nystagmus. It moves, but there is a nystagmus. So INO is a very unique example for unilateral nystagmus. Okay, but the left gaze is completely normal. So let's understand this diagram here. So the lesion is somewhere here. Okay, so the fibers passing through the left sided medial longitudinal fasciculus are destroyed. So the adduction of this is not possible, but there is abduction is possible, but it is not receiving, it feels there is some disconnect. So there is some sort of nystagmus. So abducting nystagmus of the right side and absent adduction when looking towards the right. So left INO is characterized by normal left gaze and abnormal right gaze. In abnormal right gaze, what is happening? The abducting nystagmus of the right is present and adduction is completely absent. So this is known as internuclear ophthalmoplegia. So we need this beautiful diagram again to understand the other features also. So what is a gaze palsy? The effect is here in the parapontine reticular formation. So the patient is unable to look towards the right side. So right sided gaze palsy. Simple. The patient is just not able to move. There is no nystagmus. He just can't look towards the right. Okay. So what happens in bilateral INO? Suppose there is a PPRF here, which is connected by the right frontal eye field. Then from here it is going to the lateral rectus, and from here it's going to the oculomotor neuron and the medial rectus. So what is bilateral INO? Affection of both sides medial longitudinal fasciculus. So what is happening? So what happens in unilateral INO is happening twice, that's all. So what happens in right gaze? So on right gaze you have limitation of left adduction with abducting nystagmus of the right eye, which we just learned. And on left gaze again the same thing is happening. So because left gaze you need this to function well, there is abducting nystagmus of the right eye, of the left eye, and absence of adduction of the right eye. So this is bilateral INO. I hope it is clear. You can listen to this again if it's confusing. So the next horizontal gaze palsy is PPRF with MLF lesion. Suppose the lesion is affecting this whole thing here. Okay. So PPRF is also affected and MLF is also affected. When PPRF is affected, you do not have a gaze to your ipsilateral side. So there is ipsilateral gaze palsy with INO. So what happens if there is a MLF lesion here? There is no adduction. So in the first part there is no abduction of the left eye, there is no adduction of the right eye. Because of MLF lesion there is no adduction of the right eye. So the only movement left here is the ataxic nystagmus of the contralateral side. So only abduction of the right side is left, and that too is characterized by some kind of nystagmus. So this is known as 1.5 syndrome. So let's move on to vertical gaze palsy. RIMLF or rostral interstitial medial longitudinal fasciculus in the midbrain is the vertical gaze center. Okay. The two common causes of vertical gaze palsy are Perinod syndrome and progressive supranuclear palsy. So PSP is a very ominous stage in a person's life, especially if he is already having Parkinson's disease. It signifies there is severe amount of degeneration. The patient is unable to walk because he is not able to perform vertical gazes. He is not able to write because the eye cannot move up or down. Okay. So these are the common causes of vertical gaze palsy. I hope you learned something today. So we'll be back next week with the last class of neuro ophthalmology. Thank you.